that was sort of added to the standard structure, if you like. As for sort of what's changed, I think early on there was huge uncertainty. I mean, there still is quite a lot of uncertainty about the role of asymptomatic individuals. Trying to think sort of what's come online, we probably over the first few months got a much better understanding of hospitalizations within the UK. So how to translate within the model infectious cases into those that go to hospital, how long they stay there, and then also the fatality rates. So I think just bringing in that source of data from the UK helped to refine things and helped to make the models much more accurate. Although obviously in the early stages, you know, we were all using data from Wuhan and from the cruise ships that were coming in, because that gave us probably the earliest sort of signals.
So because we were so far behind China and Italy and the cruise ships, so to what extent did that information change the assumptions that you made?
Well, I think most of the models started once there was already data available from Wuhan, so that wasn't really changing much. I think the biggest changes were actually trying to sort of understand the situation in Italy. I mean, I think it was unclear in the early stages of the Wuhan outbreak whether we were going to get a similar sort of scale in the UK or elsewhere in the world. So really, I think Italy was the big eye-opener that we realised that we could have a large potential outbreak in the UK. So I think that started changing our thinking. But you know, throughout it's a gradual refinement rather than a sort of eureka process of suddenly changing everything and the models changed dramatically.
So as you went along, did you perform sensitivity analyses on any of these assumptions?
Yes, generally, I mean, sensitivity analysis usually talks about sort of thinking about changes to parameters. I think most of us are using what's known as a Bayesian framework. So the uncertainty in parameters is already built into the model. And so our model sort of takes that uncertainty in parameters and percolates it forward in time. So we're always looking at uncertainty as we move forward. But we do also think about model uncertainty. So, you know, what if we change some of the fundamental questions and, you know, some of the fundamental assumptions in the model to how the disease is actually progressing? Does that actually change our results? And very often, given that we're already constrained to match the available data, the changes are quite mild.
Thank you. And does Dr. Kosharsky or any of the other witnesses want to come in on that?
So if I could just add to that, I mean, as mentioned, we were really trying to draw on all the available data sources that were there. In late February, for example, we did a meta-analysis of all of the severity estimates that were coming out, particularly from China, and estimating about 20% of hospitalized cases would have acute respiratory distress syndrome and about 15% requiring ventilation. So that's a kind of measure of likely ICU requirements. Obviously, there was quite a lot of uncertainty around that. And as we got more data in from other countries, we could start to narrow that. And I think similarly with other kind of key metrics, things like the infection fatality rate, even quite early by pooling data sets. I mean, we did some analysis and Imperial independently put together some estimates suggesting that probably between 0.5 and 1% of infections would be fatal. And then obviously as more data comes in, we can then see how those estimates are holding up, and what might have started with quite a large uncertainty range will narrow.
So going forward, Professor Ferguson, what does the models tell us?
That's a very large question. I think we have seen, coming back to the question just asked, one of the things which we learned in early March, soon after that, was the UK had been much more heavily affected than we had previously anticipated, really in early March from Spain and Italy. So that is one of the reasons we have, if not the largest, one of the largest epidemics in Europe. Going forward, what the models say is that we have limited room for maneuver, that this is a highly transmissible pathogen. We've reduced transmission by about 80%, but to maintain control, we need to keep that transmission suppressed by about 65% or so. So we have a little bit of wiggle room. So it will be a learning experience as to how we allow society to resume whilst maintaining control of transmission.
What are the other?
Can I just ask about the granularity? We've learned a lot of detail as the pandemic has gone along about the sorts of people who are most badly affected. I'm thinking of people with obesity, the BAME population, and so on. Have those bits of knowledge made any changes to the assumptions that you're making as we go along?
I think as Matt and Adam said, we feed in that data in terms of modeling, particularly what the health impact of the epidemic is, but it doesn't necessarily make a change to the fundamental assumptions about transmission. One of the things which is interesting, I mean, yes, the ME population has been very badly affected, but it's not clear whether that's an independent risk factor, ethnicity I mean, or is correlated with, frankly, socioeconomic status, ability to shield. What we've seen in this epidemic is clearly the middle classes and the wealthy are much more easily able to isolate themselves than people who have to go out and do essential jobs. Also risk factors like cardiovascular disease, obesity, as you mentioned, some of these risk factors have higher prevalence in BAME groups. So it's a very complex picture.
Banashir.
Uncertainty. May I ask the panel, how do the models account for uncertainty in individual behaviour despite population level regulations? May I start with Dr. Brooks-Pollock, please?
Yeah, well, so the models range in complexity from simple, which don't capture much individual variation, to more complex. And I mean, one example, we've been using social contact data, and that tries to capture the variation, individual variation, to look at what kind of impact that has. So yeah, so it varies by model complexity, and I mean, essentially it's the data that feeds into the model that enables you to capture these individual variations.
Could I also ask the other panelists if you can add to the question the following one as well. The public's adherence to lockdown appears to be better than expected, and as evidence of this emerged, did it inform the model's assumptions?
Maybe I can comment on that, because at the time we were all, I'm talking about in late February, early March, modelling the potential effect of social distancing and other measures. We basically had to make assumptions about what population adherence would be, because we didn't really have any data. And so you're right, what we actually saw was greater adherence than expected. And that immediately fed back into the models.
Would anyone else like to comment?
Yeah, I mean, I'd echo that. I mean, a lot of the models are being fit to sort of epidemiological data, so sort of, hospitalizations and things. So really, it's very difficult to directly translate adherence to the lockdown measures straight into something that tells you about transmission. So, if we know that 85% of people are obeying the lockdown, that doesn't immediately tell us what the drop in R is. So we also have to factor in data from hospitals, deaths, and other factors that tell us about how that drop relates to an epidemiological change in transmission. So there's a two-step process in there. So although that information is incredibly useful and sort of very quickly allows us to say, well, our early predictions may have been too pessimistic, we're still lacking the information to know how to translate adherence directly into transmission.
Okay, The public's adherence and the assumption early on that it would be quite low did affect policy from decision makers quite substantially, would you say, given that it delayed lockdown because they felt that people would fatigue in isolating would set in. So I just wonder why that assumption was made that people's behaviour would be so different to what turned out to be the case.
So I don't think it was that. So first of all, I mean, I think the issue of which has been discussed, of the idea of fatigue, was not something we ever modelled. I mean, some people had that view on SAGE, but it wasn't one I shared or other modelers looked at. I think the difference in adherence was we assumed, for instance, there would be a 75% drop in contacts outside the home. And there's a benefit to being conservative when you're looking at, how effective the policy would be. There turned out to be more like an 85% drop. So we're talking about differences, but not differences which make a qualitative change to what you predict a policy to do.
I think if I could just add to that as well, we considered a range of reductions in the model, and obviously in a model to change the parameter, so you've got a 50% reduction in outside contacts, or in one scenario we looked at a 90% reduction, and likewise with some of the more recent contact tracing analysis around adoption of an app, optimistically we assumed perhaps half of the population might end up having it. That can present a scenario that if you manage to achieve that, it gives an indication of what transmission might be, but obviously there's a much wider set of questions about how you might do that and what the messaging and policy might be that ends up giving you that value.
Thank you. And I just want to finish off by asking a question about the R value, and just wondering how uncertainty in R naught is taken into account in models, and how sensitive are models of different interventions to different values of R naught.
So maybe I'll start briefly. So we, in a lot of analysis, used a kind of a range of values of R naught. So in a lot of our scenario analysis in early March, we were using, I think, values that range from about 1.5 to 4, which was from early data, the sort of plausible range we would see. And obviously some specific suggestions about how many numbers of cases, for example, you see will be dependent on a reproduction number, but in many cases the relative impact of interventions may be less dependent. So for example, we more recently looked at isolation, contact tracing, social distancing, and the kind of the relative ordering of those in terms of effectiveness is less sensitive to R, but exactly the reduction you'll see is more dependent on what you assume.
Wycombe Ridley, you want to come in?
Yes, may I ask a supplementary on this? A number of mathematical analyses have concluded that the lockdowns may not have had such a big effect as we are thinking, because the trajectory was already beginning to bend because of voluntary measures and the no large gatherings and things like that. I mean, to quote from a recent study of the lockdown in the UK, Spain, France, and Italy by Thomas Meunier, a mathematician in Canada, he said, comparing the trajectory of the epidemic before and after the lockdowns, we find no evidence of any discontinuity in the growth rate, doubling time, and reproductive number trends, and goes on to conclude that lockdown may not have saved any lives. Would any of the panel like to comment on that?
I would strongly disagree with that. All our modelling suggests that the lockdown had a major impact on the growth of the epidemic. There's a very clear step change. One of the difficulties with trying to analyse this is the huge delays and range of delays that are in the system. So, you may do a lockdown or change in policy one day. You're not going to see that impact in hospitalisation for at least a week, if not longer. And very often these things may take 1 or 2 generations to actually cycle through the population, because if you suddenly do a lockdown and people are more have stronger interactions within their household, that will keep the epidemic going for maybe another generation. So it can be 3-4 weeks before you see the impact of any lockdown. So I think you've got to be very careful with some of these analyses.
But wouldn't that make the problem worse? Sorry, wouldn't that work in the other direction? In other words, if the lockdown doesn't have an effect for several weeks, then you would think that the peak would come even later. I mean, it came quite early in April.
Very brief answer, please. I need to move on.
Sorry.
If I could just add to that quickly, so there's a slightly counterintuitive thing that goes on here, because if you have a sudden drop in transmission, most of your burden of infection occurs before that drop, and because you have this distributed delay, it's not the case that you'd have a drop in infections and see a simple drop in deaths 3 weeks later. It would actually spread it, and you would get a peak earlier. So as mentioned, a lot of the analyses that have rigorously accounted for these delays do reproduce these shapes we've seen, and it's not just a simple case of moving the curve along by a few weeks.
Okay, Baroness Rock.
She's muted.
No, Baroness Rock, you muted. Please don't touch the buttons. You'll be muted and unmuted, all of you, by the.
Thank you, Lord Chairman. Apologies for that. I'd like to explore a little bit more the different models, if I may. And were there any significant differences between the models being used by SAGE? And if so, what were they? And were there more optimistic scenarios and some reasonable worst case scenarios between the different groups? Professor Ferguson, perhaps you'd like to start.
So I should say the reasonable worst case scenario is a government scenario, and it's determined basically as a consensus judgment of what is exactly that, a reasonable worst case for government to be planning to. So the exact model which has been used to generate the reasonable worst case is actually varied over time. Right now, it's actually Matt Keeling's model, which is has generated the current reasonable worst case planning scenario. Those planning scenarios are updated through time. They're based on data, but they're deliberately intended to be challenging for government to plan to. The challenge we had in early March, though, was we ended up with a reasonable worst case scenario, which was, in my view, very close to the best estimate of what would happen. And that can lead to a kind of slight disconnect that in thinking. In terms of policy making, there was a kind of view almost, I think, that, well, this is the reasonable worst case. We're not going to see anything quite as bad as this. And I think both myself and John Edmonds weren't quite so sanguine about that. I think there are always differences between modelling groups. So the precise estimates of what the reproduction number is, what the infection fatality ratio is, will vary. But they were always, and have been throughout this epidemic, similar enough that you could have a fair degree of confidence that the differences would not be a qualitative difference in terms of policy conclusions.
Thank you. Professor Keeling, perhaps you'd like to come in.
Yeah, I would just sort of echo that yes, there were differences, but in general, we worked very closely to try and resolve those. So I think SPI-M, one of the subgroups of SAGE, has been incredibly helpful with that. That, you know, we do have weekly, if not more frequent meetings, certainly early on, where we do look at the outputs of all the different models and try and reach a unified scientific consensus, which isn't just about taking an average, it's about trying to understand the differences as well. So it's very much a sort of judgmental opinion that's based upon taking all the evidence from all the different models and looking at what the predictions will be going forwards. So I think that's been incredibly helpful throughout. In terms of the differences, as Neil said, when most of the differences are relatively minor, and I think mainly they come from the different assumptions that are going to be used and the different data feeds that are used. You know, how much do you decide to trust hospitalizations versus the mortality rate? So it's just questions like that and nuances that really sort of influence things.
Thank you. And if I could just ask a supplementary, I just wondered if the panelists could comment on the differences between modelling approaches undertaken in the UK and in other countries. Perhaps who would like to take that?
I mean, I can comment because we are supporting a lot of countries and we are working with a lot of other countries. I don't think there are huge differences. There are differences in how science interfaces with policy by country, big differences. But I think the range of models we use here, first of all, some other countries are using models we've generated, but also the models being generated, say, used in France, Germany, United States, are qualitatively very similar and coming to similar conclusions.
So are you saying, Professor Ferguson, that the science is the same, or the use of science is the same in every country, but the policies are different? And the example you didn't quote was Sweden.
Yeah. So I have the greatest respect for Anders Tegnell and scientists there. They came to a different policy conclusion, but based really on quite similar science. It will be, I mean, they make the argument that countries will find it very hard to really stop second waves, and their policy, therefore, by in some sense front-loading the health impacts, will allow them to kind of leave lockdown earlier. I don't agree with it, but scientifically, they're not that far from scientists in any country in the world.
Anybody else like to comment?
Yeah, I mean, just to say, I would agree with that. I mean, we would hope that the science and the predictions from all countries would be very similar. There is the fundamental underpinning these SEIR models that we've all been talking about, these compartments that we put people in. So we would expect very similar types of predictions based differences on the data and the population structure, but we would expect very similar predictions, similar science to be coming out from all the countries. And I think it is about this interpretation of, and really a value judgment of, you know, what do you believe is going to happen in the future? You know, if we believe a vaccine is coming soon, then you want to clamp down on the first wave as much as you can. If you believe that we have to get through this one way or another, then you may decide to front load a Sweden that's done. But it is really about how you do the trade-offs between and also sort of between economics and epidemiology, and where you put the inference.
Can I just add as well, although we're talking about the similarities between the different models, I think it's hugely valuable that there are multiple different models, and often the differences between them have been quite insightful into what the important processes are. So I think it's essential that multiple models contribute to and are discussed at SPI-M rather than evidence for policy just being made on a single model.
Thank you very much.
Okay, Viscount Ridley.
Thank you, Chairman. I'm surprised by what Professor Ferguson just said about Sweden, and I'd like to come back to it before I move on to R and R0, if I might, because Uppsala University took the Imperial College model, or one of them, and adapted it to Sweden and forecast deaths in Sweden of over 90,000 by the end of May if there was no lockdown, and 40,000 if a full lockdown was enforced. In fact, there have only been 4,350 deaths in Sweden to the end of May. This does seem to be a huge discrepancy and suggests there was something wrong with the model. We've heard today that on the whole, the models are thought to have performed well. That doesn't sound to me like they have performed well. But we are looking
okay,
forward.
let it
can I just maybe respond to that quickly? First of all, they did not use our model. They developed a model of their own. We had no role in parameterizing it. Generally, the key aspect of modeling is how well you parameterize it against the available data. But to be absolutely clear, they did not use our model. They didn't adapt our model.
Yeah, but surely the key point is that without a lockdown, from what we've just heard from both Professor Ferguson and Professor Keeling, one would expect a relatively high death figure in Sweden. It's in fact much lower than
I think that is an interesting question. It's clear that there has been significant social distancing in Sweden, and our best estimate is that has led to a reduction in the reproduction number to around 1. It's clear when you look at their mortality, they're not seeing the rate of decline that most European countries are seeing. But nevertheless, it is interesting that adopting a policy which is short of a full lockdown. They've closed secondary schools and universities, and there is a significant amount of social distancing, but it's not a lockdown. And they have got quite a long way to the same effect, albeit there's no evidence of really a rapid decline in mortality there in the same way as other European countries. And so that is something we are looking at very closely. I mean, lockdowns are very crude policies, and what we would like to do is have much more targeted control of transmission going forward, which doesn't have the same economic impacts.
Why can't Ridley, you have to move on to your question?
Yes, particularly about R and R0, but zeroing in on one particular aspect of it that I find puzzling. The SAGE minutes from the 20th of March show that SAGE knew then that a major problem of the infections was nosocomial, that is hospital acquired, with a very high and rapidly changing R inside hospitals and care homes, and a much lower R in the community. Was there ever any prospect of an overall average estimate of R being useful?
Who would like to start? No one?
I'll start with that. I mean, it depends on what you want to use that R estimate to give you. I mean, the standard usefulness of R comes because it tells you what your case burden and hence your fatality burden is going to be in the coming weeks. So if your cases are flat, then you're going to see that the implications of that in the coming weeks, regardless of where those cases are happening. So in that sense, an overall R is useful. But of course, if you're talking about targeting control measures, then having that finer scale data on exactly what settings are driving transmission. And obviously more recently, we've seen a lot more transmission being concentrated in care homes and healthcare, which needs to obviously feed into discussions about how we're targeting controls. So I think it really comes back to what are you using those R values to try and estimate.
But we heard last week from one of our witnesses that what may be happening now is that transmission in the community may have been very low because of all the lockdowns and other measures, and that most of the cases that are happening, even in the community, are coming back out of the hospital and care home settings. So in a sense, it's a high R in one part of society that is keeping R slightly higher than it would otherwise be elsewhere in society. So this heterogeneity of R does seem to me to be certainly underestimated in policy conversations and possibly also in modelling.
I agree. I mean, that hypothesis is the one actually we have been considering a lot in recent weeks, and it's the most likely one to explain why R is one. And there has been modelling of hospital transmission. It's quite hard to build a model which includes both hospitals and the community and is parameterized reliably. But that nuance is understood in the kind of interface between science and policy. I mean, I, like many people, am shocked about how badly European or countries around the world have protected care home populations. That's a slightly different issue from science, though.
So going forward, what does it tell us?
If we had done a better job, or did do a better job, of reducing transmission in closed institutions like hospitals and care homes, we would have a little bit more room, wiggle room as it were.
Somebody shuffling their paper. Please go on, Lord, Professor Ferguson.
These epidemics are not completely separate from each other, they're coupled. As Lord Ridley said, I mean, the infections in care homes and hospitals spill back into the community, both through the people in those, well, more commonly from the people who work in those institutions. And so if you can drive the infection rates low in those institutional settings, you drive the infection lower in the community as a whole.
Okay. Michael Ridley, you done?
Yeah, thank you. Yes, Chairman. Chairman.
Baroness Manningham-Buller, please. Baroness Manningham-Buller, please don't touch the button. Steve? Steve? Steve, can you unmute her? Balance Maningambula. Steve, can you hear me? Steve? Can you hear me, Steve?
I've ignored it and I've unmuted myself, which I know.
No, we can hear you now. We can hear you now.
Thank you. I'm sorry to have been slow in coming in. All the witnesses have told us, I think, about how some of this is pretty difficult because we have incomplete information about the virus and uncertainty, although we're learning the whole time. I'd like to ask the witnesses, looking back, at the beginning, there were some quite worrying assumptions about the death rate, and the modelling was, I'm not saying alarmist, but there was some worrying data coming out. Looking back, how much do you think we got right, and how much we didn't, and why? I do very much recollect Patrick Vallance saying that 20,000 deaths would be a good result, which seemed at the time to be a deeply shocking remark. Well, actually, we're nearly double that. So what is the explanation of that gap between the early modelling and where we are today?
Maybe I'll start. Matt, go ahead.
Go on, I'll have a first punt at this. So, I mean, I think what we're doing is we're modelling a constantly evolving situation. So we can only predict forwards from the data that's available at the moment. So in the early stages, in the absence of a lockdown, the value of, the very alarmist values that were coming out were really about a worst case scenario. So if we just let the epidemic run, how bad could it be? And that's the sort of information that policymakers needed at that time. The comment that you made about the 20,000 deaths, as a sort of, we'd be, if things went well, we could have 20,000 deaths. Well, I think, that's been borne out. If the lockdown would have been very strict, if we'd have thought more about what was happening in care homes and hospitals, as you've heard, I mean, early on, maybe that's one of the areas where modelers did drop the ball. We should have thought, with hindsight, it's very easy to say, oh, well, we know care homes and hospitals are these huge collections of very vulnerable individuals. So maybe with hindsight, we could have modelled those early on and thought about the impacts there. But I think, considering the amount of information we had at the time, I think the models offer the sort of, our best estimates of what could happen in the short term. Long-term predictions are much, much more difficult. And very often our models have quite large confidence intervals, but what gets reported is just the mean. So there's a whole raft of different elements that need to be brought into this.
I suppose a sort of supplementary, which some of the others may like to come in, has what surprised you between the predictions on possibly incomplete information in February and March and where we've got to?
Well, I mentioned earlier that one thing, actually the genetic data is showing us now, is most chains of transmission still existing in the UK originated in Spain, to some extent Italy. So what we had been worrying about importation of infection from China, we're a very well connected country in the world, from other Asian countries, maybe the US, but it's clear that before we were even in a position to measure it, before surveillance systems had set up, there were many hundreds, if not thousands, of infected individuals came into the country in late February and early March from that area. And that meant that the epidemic was further ahead than we had anticipated. It explains some of the kind of acceleration of policy then, but it also explains why, to some extent, why mortality figures ended up being higher than we'd hoped.
If I could just add to that, I mean, I think early on as well, we had pretty good evidence that what China had done as implemented had suppressed their transmission, and that if you were to only introduce very light measures and sit back, you'd quickly have a health system that was overwhelmed, and we had empirical evidence from Italy that was the case. But the uncertainty was very much in the middle of all of these measures that are coming as part of lockdowns. I think often we talk about a lockdown or not, but obviously lockdown in the UK has not been the same as lockdown in Italy or in China. It's really a basket of interventions. And I think we're seeing, as countries lift measures, the variation in the ordering and the timing that they're doing that really reflects that there's still a lot we don't know about exactly how much each of these is contributing to control.
So looking ahead, accepting that there's wide confidence limits in models, what in the short term and the medium term are the models saying is likely to happen now? Nobody?
So, I mean, one of the key issues is how much will relaxation of current controls lead to potentially increases in transmission. I should say it's not clear that it automatically will do so. But most of the modeling would suggest we might get a small increase, but it's very unclear whether that will lead to the reproduction number being above, which of course leads to infection, we will still stay just below 1. So, I mean, there is a lot of uncertainty right now. I suspect, though, under any scenario, that levels of transmission and numbers of cases will remain relatively flat between now and September, short of very big policy changes or behavior changes in the community. The real uncertainty then is if there are larger policy changes in September, also we move into, time of year respiratory viruses tend to transmit slightly better, what will happen then? And that remains very unclear.
Okay.
Yeah,
Bernice,
I mean,
yeah, go ahead, please.
Sorry, I mean, the only thing I would add to that is, we are assuming that adherence and changes to the lockdown rules apply to the UK as a whole, or England as a whole, depending on whether it's a national figure or not. I think if there's sections of the community that start adhering less well, then we could see more pockets of infection arising. So there's another area for concern, and one that would be very hard to try and model because we just wouldn't have those individual level behavioural details that have been mentioned before.
Okay, I have a quick supplementary from Baroness Blackwood and then Baroness Young. Baroness Blackwood.
Thank you, Lord Chairman. I'm interested in the intersection between modelling and measurement. And as we sort of ease the lockdown and introduce test and trace, I'm wondering if this will enable us to more effectively estimate variations in transmission. I think this is called the K rate, and whether we will have more accurate transmission, and this will enable more sophisticated policy measures at a local level.
If I could just come on that briefly, I think that would certainly be useful the more data we can have. I mean, a lot of our understanding of which settings and which kind of interactions drive transmission come from detailed contact tracing studies in other countries. And if you look, for example, at Korea with their extensive testing around clusters, that gives a lot of insights into how transmission is happening. And in turn, that can inform refined control measures. So I think the hope is that if we do have detailed surveillance and increased testing, that would give us a more accurate picture of where and how transmission is happening. And then in turn, that can inform potentially more effective and less disruptive control measures.
Increased testing of whom?
As a baseline, increased testing of everyone with symptoms. But I think also those studies that are following up individuals who are potentially exposed. So that would be through contact tracing, testing of people at risk can give insights into the sorts of settings and interactions which might be driving transmission.
Would that include screening as a method, perhaps, of those in areas of higher rates of infection, such as care homes and NHS settings?
I think that would certainly be useful. I mean, some of the data that's been coming out, for example, of UK hospitals where there's been widespread screening tests have given some idea of what the prevalence of asymptomatic infection might be. So I think particularly those high-risk environments, as well as having implications for control, it could help us, as we've heard, really get at these cases that have very little or no symptoms and what potentially they're contributing to transmission.
Bernice Young?
How much modelling has there been of varying degrees of success of the test and trace regime as it goes forward, and how widely variable are the outcomes if there is greater or lesser success?
Ourselves, Matt Keeling and Adam have all looked at it, looked at different likely policy effectiveness. It is not a panacea for the reasons that Adam and others have said. It depends on not just what proportion of people show symptoms, but then what proportion of people can actually identify contacts, what proportion of contacts are identified, and then how quickly they're identified and what proportion actually then adhere to isolation. And we're asking people a lot to isolate for 14 days. So the modeling has reflected that. We've done a lot of sensitivity analysis. If it works perfectly, we think it might reduce the reproduction number by 0.2, 0.25, which is significant but not huge, but it could be less than that.
Okay. Lord Borwick? Lord Borwick?
Hello. Professor Ferguson, I don't trust the newspapers, but one or two of them have suggested that the original imperial model was written in Fortran, a rather elderly program. Was there any truth in that at all?
No. I mean, it was written in C, which is also an old programming language, but is one which is very actively used today.
Certainly.
And I should say we have just released the files which allow people to reproduce the results in our report 9, so people can check themselves.
Thank you.
Okay. Lord Winston, you were waiting for a while.
Sorry, it's this muting business. My Lord Chairman, my question's been answered. Thank you very much.
Okay. Well, has anybody else got any supplementary? Please raise your hand, otherwise I'm closing the session. Any of the witnesses may want to make a brief final comment? No? Well, thank you all very much indeed for coming to help us. It's been the most interesting session and we've learned a lot. So thank you. We appreciate it. I'm going to move on to the next session now. And can I welcome our witnesses for the next session, please? I think they've all logged in, Steve, have they? Professor Woolhouse and Dr. Birrell have logged in, I assume. I know that Professor Hollingworth is not able to attend, so we have Professor Woolhouse and Dr. Birrell. And can I start by welcoming you both and thanking you for coming today to help us with our inquiry. And I'm going to ask Lord Mayor to start the session off. Lord Mayor.
Thank you, Lord Chair. In the first session, we've heard a great deal about different models, different assumptions. I think you were both present and able to hear the witnesses' responses. What would you like to say about the different modelling approaches that have been used in the UK's response to the pandemic? Perhaps Professor Woolhouse, would you like to start?
Oh, thank you very much. Good morning. It's a pleasure to be here. So the first thing I should say perhaps is that I was co-opted onto the subgroup of SAGE, SPY-M, at the beginning of this pandemic. So where my group is not one of the core modelers, we don't produce the outputs of Professor Ferguson or Professor Keeling and the others that you heard from before. We play more of a support role. And I should say I have a huge regard for the work that SPY-M does. In terms of the range of modeling, well, you heard a very detailed answer from my colleagues before. But I think if we take a few steps back, the picture is a little bit different. So SPI-M stands for Scientific Pandemic Influenza Modeling Group. And all these models had their roots in influenza modeling. So that's one issue. This virus is not influenza. In fact, it's turning out that its epidemiology probably has more in common in many respects to an earlier coronavirus, the SARS coronavirus. So that's one issue, and the models had to be adapted to adjust to this new reality of the COVID-19 virus. The other issue is what the models have been asked to do. And this modeling committee has been set up for a long time. It works tremendously well. I've huge admiration for the way this has been set up. But it's set up to answer, or has been used to address a very narrow set of questions. And largely, those have been to do with a population-wide social distancing, lockdown. It has not been used to explore other possible ways to respond to this particular epidemic. That's absolutely not the fault of the modelers. They're doing what they want to do. So I think you have a uniformity of outputs because the models have similar histories and they've been asked to do much the same things.
Dr. Birrell, would you like to comment?
Yeah, if I may come in on that, there's a continuum of modelling approaches that get used. As I think was mentioned in the previous session, they're often based on this susceptible, exposed, infectious, recovered type stratification of the population. But how the models are used is often varies greatly. So the more complex ones are sort of agent-based models, the kind of modelling that Neil Ferguson would do, would model every tiny detail of the pandemic. And there's more statistical approaches which just exist to react to data and don't necessarily look at the underlying mechanisms of transmission of the virus, but will respond to fluctuations in data and will incorporate other data sources and they're more statistical in their approach. So there's a bit of focus generally on mathematical models, which what happens if you tweak a parameter and you make projections about what might happen in the future. But there's also the modeling, which they tend to be simpler models, which allow you to incorporate the data and build up an accurate picture of what has happened so far, usually at the coarser stratification of the population. But they allow you to come up with robust estimates for quantities that you think are key to the epidemic's future.
And could you say a bit more about how these statistical models thrown new light on some of the modelling we've heard more about in the earlier session?
For example, sorry, I have to make sure my laptop's plugged in. For example, a large agent-based model will be able to, you can challenge it with a relatively small number of parameter sets. You can consider still probably in the thousands number of scenarios and see what possible futures you get. In more statistical approaches, you can use a greater array of data. You can model it of a finer spatial scale because the models are simpler, and you can get localized parameter estimates where they're available. There's other considerations there. You're reliant on good local data and the data being not too noisy, which often happens at local data. They're separate issues, but you can get. I think they're of greater utility, and where they're mostly used is in terms of short-term forecasting. So what is going to happen over the next couple of weeks? The longer-term, more detailed sort of scenario-type modelling, that's good for giving really good qualitative statements for what's going to happen in the future and what might happen for a particular intervention. But in this, for communities, what's coming, what can we expect in the next 2 weeks, next 3 weeks? The more statistical models have greater utility, but they don't have that structure which will allow you to project into the future.
And can I ask a sort of supplementary with having heard that response, asking both of you, in hindsight, are there other modelling approaches that could have been useful to aid decision-making on interventions?
If I may carry on, interventions tend to sort of be looked at in the longer term. Although policy is constantly changing, you're looking to, no one was implementing a lockdown expecting it to last 2 weeks, or the duration of time in which you might use a model that's particularly good for forecasting. So you do need the more detailed mathematical approaches, and I think what has been done is absolutely right for assessing the potential impact of policies. I think the mathematical models are absolutely essential, and SPIAM focuses on those for assessing the potential impacts of different scenarios and different policies and different adherences to policies.
Professor Woolhouse?
So with hindsight, I agree with everything that Paul has just said about the statistical models. But there is an issue here as to how well you can actually look into the future using the more detailed models, because what you're having to do is make estimations about what behavioral changes will happen in the future, possibly in response to interventions, social distancing measures and so on. You're having to work out how those measures will translate into actual changes in behavior, and what those changes in behavior will then do to change the rates of transmission of the virus. And all of those things are extremely difficult to do. In the background situation, so when people are behaving normally, there are very good data sets, although somewhat out of date now, and that my colleagues in the earlier session were using these, that tell you how people interact and how that might influence the rate of spread of the virus. But once something like this comes along, whereas you've heard there's not only regulations to change behavior, but a lot of spontaneous behavior change, both at the individual level and the institutional level, shop or whatever, we don't know at that point what's going to happen next. So it is very, very important when you're trying to look into the future and look at interventions that you do model a very wide range of scenarios, because that's all they are. They're just possibilities, things that might happen next, and not predictions. We can't predict with this virus.
And do you think these wide range of scenarios are already being modeled?
Well, the approach that my group takes, which is a different approach, and it's not feeding directly into policy. Let's call it a reality check. But we model hundreds of thousands, possibly millions of different parameter combinations to reflect the fact we're not sure. We don't know exactly what's going to happen next. So let's look at the full range of possibilities and see what comes out of that looks robust, and what comes out of that looks fragile. And that's a very, very important exercise, I think.
Okay, Lord Keika.
Thank you, Lord Chairman. Just to move on to to understand a little bit more detail the approach that's being taken towards the evaluation of models that are having such a big impact, both in terms of our public health strategies and as a result of the policy that's derived on our economy and the broader well-being in society. How does this evaluation take place? What is the methodological approach that's used to determining whether a model that is being used in such a profound way is indeed appropriate? And how, for instance, is an assessment made of the quality of the inputs and data inputs into these models? Dr. Birrell, would you start?
Yeah, I think to answer that question, it's necessary to build on something Professor Woolhouse just said, is that that these models come up with potentially many hundreds of thousands of scenarios, but what these models don't do is rate the relative likelihood of these scenarios. They're just a list of possible futures or possible alternatives of what might happen. So if something happens in the real world and we observe something that is different to what the models might have predicted, it's not necessary to say that the models were performing poorly or were necessarily wrong. And then there is a distinction between the the model being wrong, and all models are wrong, but some are useful to quote the famous quote. It's not necessarily the model being drastically wrong, but it might also be the parameter sets that it's being challenged with might be not quite right in some way. So it's often not so much the model, but the parameters that should take primacy in this case. How they're assessed, well, there's going back to again my previous answer. There's two approaches. There's the prospective modelling, and there's how we deal with data. And over time, as data becomes available, the models will be used more formally to react to that data, to estimate parameter values. And the greatest thing you could do is to contrast what the parameter values that you challenged your model with in the first place when you were prospectively assessing what might happen with what you estimate eventually when you have some data on the outcome that you're interested in. So, I mean, for example, a lot of the early modeling in early February kind of time, we were assuming R values, the more famous parameter that everyone seems to know about, R values in the range of 2 to 2.4, and looking at what might happen under those circumstances. And subsequently, what we now know is that R was actually much closer to 3. It was in that kind of ballpark, which has a significant impact on what would have happened if the epidemic had been allowed to run unmitigated, and also the potential impact and the cost, the burden that has been saved by having the lockdown intervention.
Professor Woolhouse.
So this is a very good question. Verification and validation of these sorts of models that are being used in real time has always been extremely challenging. I've worked in this area for 40 years, and that's been a recurrent question: is how do you do that to make sure that your models are behaving as best as possible? There are 3 broad approaches to it. First of all, before even attempting to use your model looking forward, does your model capture what's already happened? That's sometimes referred to as hindcasting, but can you confirm that your model captures that? The second thing is, then does your model make predictions, and do those predictions come true? Do they consistent with the data? But Paul and I have both said that actually in this particular case, that's extremely difficult to do because things are changing so fast, including people's behavior and indeed the government policy to change people's behavior, that's really quite hard to do. So the other thing you can do is look at variables that are reported in the analyses that you didn't explicitly model. So just to give you one example of a very simple model we were running, it predicted the number of people infected in a given time, or modeled that, and it also predicted the number of people who had been exposed. Now that wasn't something at the time we had data on, but it's the people basically who are showing antibodies, but it predicts that. And then the antibody data came out. The first batch that was reported by, I think, Patrick Vallance at one of the press conferences. And he reported a particular figure. So I asked my team immediately, oh, what's our model saying about today's, or sorry, actually last week's level of antibody positives? And they said, oh, it predicts about 6%, which is exactly what Patrick Vallance said. So we felt reassured that our model had successfully captured something that it hadn't got any data inputs for. And that sort of internal validation happens continuously with all these models.
And on that basis, I mean, how often have those approaches been used? The middle approach we accept is difficult in a fast-moving situation. But the 2 other approaches in terms of testing the models that we've become so dependent upon for development of policy.
If I may start the answer there, SPY, the SAGE subgroup on which both Mark and I sit, the SPY-M, has a further subgroup on forecasting, and weekly each team, there's sort of 6 or 7 modelling teams. Matt Keeling and Neil Ferguson lead 2 of those teams, and Ellen Brooks Pollock also works on one of those teams. We provide forecasts for what's happening in the next coming few weeks, There's independent oversight provided by DSTL, a team from DSTL, who measure the forecasts. And what we find is that different teams forecast different quantities, or the different models are sort of trained to focus on different quantities or forecast different quantities well. So the modelling I'm involved with seems to forecast the deaths well. Matt Keeling's work is better at estimating hospital bed occupancy and so forth. And so as an ensemble, we can build together sort of a groupthink type of forecast, and we can gather each other's strengths and come up with forecasts that are better equipped based on the totality of our modelling attempts rather than individual modelling attempts. So it's not so much assessing the individual models, it's more combining them and using their gathered strength to sort of see what the picture is, what's going to come in the next few weeks, and how we appear to be doing in terms of accurate building of a picture of the pandemic.
Okay, thank you very much. Lord Hollick.
Thank you, Lord Chairman. I think the thread that's come through, run through all of the witnesses we've heard today is uncertainty. And to what extent have the modelers been able to change their approach and possibly their parameters and the input data to take account of this, this uncertainty? Because I think the impression that's been left with the public is that here we have a scientific and talismanic figure that politicians then use to inform their next policy move. But what we're learning today is there's a great deal of complexity and indeed uncertainty in this. And I want to go back to a point you made, Professor Woodhouse. You said that the use of the data was very much focused on social distancing, which rather begs the question: what should it have been? What should it have been focused on, as well as social distancing?
Thank you. I said, I hope I said specifically population-wide social distancing, so a blanket approach. What the models were not asked to do in the original stages was focus very much on where the public health burden of this infection lies. It is vastly, vastly disproportionate. 3/4 of all the deaths due to COVID-19 in the UK have been in the over 75s. Of those 40,000 deaths, 3 have been in the under 15s. The burden of this disease is vastly disproportionate. So as a worker in public health, so I've been in this field for many years now, I would naturally expect in a situation like that, that the public health response would be massively targeted where it was needed. It's needed roughly 10,000 times more in the over 75s than it is the under 15s. So I wouldn't expect to see a population-wide response of any kind. I would expect to see a targeted one. And so far, there has been not so much interest in targeted responses, except in very particular circumstances, which I'm sure we'll come back to. And the models haven't been asked to and haven't really considered those targeted responses in detail. For example, shielding, very appropriate strategy because people particularly vulnerable to this virus, has been part of the government policy across the UK nations practically since day one, since the very early stages. That's not included in any of the models. So we're not aiming the models at the right target. We're aiming them at everybody, when in fact the burden of this disease is very, very concentrated in certain groups.
Dr. Birrell, would you like to comment on that?
I agree entirely with what Mark says. When looking at the attempts of the impacts of something like shielding, I think we were asked once to look at it in February or so kind of time. It was still look at population measures to improve shielding and not highly targeted ones. So yeah, we typically react to commissions that come from SAGE, which presumably come from Cabinet's office in turn, and they tend to be targeted at population level impacts.
So in a sense, possibly not all the right questions being asked. Has there been any move amongst the modelling community to seek to persuade policymakers that there should be greater focus on some of the subpopulation issues that you and Professor Woodhouse have mentioned. Has that been a topic of debate and discussion?
Well, one discussion is the possible, and I think there is disagreement on this one, is the possible regional application of measures. So there is regional disparity. London has seen a sort of more, not saying more rapid growth, but a greater level of infection prior to the lockdown, and correspondingly has had a much more rapid decline since. So there is a question to be asked whether or not London could have a differential relaxation of measures to elsewhere in the country. With respect to age, that is still not one, and maybe Mark would like to add to this. There's still not one that has been widely discussed. I don't think.
Professor Woodhouse.
Woolhouse. Yep. Yes, with regards to age, so there's an enormous amount of modelling activity going on around the world. And if you just go into the preprint servers, you'll find any number of papers on modelling different aspects. Some are good models, some are less good models, some you can't really tell. But yes, there has been an enormous amount of interest in trying to model alternative approaches to population-wide social distancing. But it hasn't yet become what you might call the mainstream modelling direction by my colleagues in the scientific community worldwide. It's more of a niche activity at the moment. We've done a lot of work on this in my own group, and there is work out there, but as Paul quite rightly said, this is not what's been fed down into SPI-M from SAGE and Cabinet Office.
If I may come back
Go ahead.
If I may come back in on that, well, two things I want to make brief comments on. There has been, latterly, there has been modelling done by a team in Manchester on the epidemic in care homes, but that has not been to assess particular interventions. They've not been tasked with assessing particular proposals or particular policy changes. That's just more attempt at quantifying what's going on. And the other age differential that we are asked to look at is the impacts of school closures. Obviously, that's a very hot topic. But again, it's not protecting a very vulnerable group, but it is implementing an age differential policy.
And just a final point, is the testing and lack of testing and tracing data and other data hindering this more granular regional age-based approach?
It is. So particularly when looking at granular modelling, you need to have good data in each sector of the population that you're seeking to model. So if you're looking at death data alone, you can't build up a really reliable picture of what's happening in the under 15s because, as Mark said, there's only been 2 deaths in that age group. So you don't have the richness of data to sort of infer something useful about what's happening in that group. And similarly, at a regional level, the data that we have at a really fine regional scale either tends to be noisy, so it might be data on sort of app-based symptom reporting or number of positive tests in a particular region. So the PHE line listing of confirmed case data. But these data are really largely subject to ascertainment effort, particularly the confirmed case data. So the number of positive tests is yes, relevant to the number of infections in a particular region, but it's more perhaps relevant to the number of tests given. And until recently, until the data on the different pillars of testing were made available, that didn't exist to support the use of that data at a fine spatial scale.
Okay, thank you very much. Yes, Professor Woolhouse.
Can I just, would you mind if I said something on the granularity issue? Because I think that is very important to understand the limits to the granularity of these models. For example, a question came up recently, would it be safe in terms of R numbers, particularly to open small shops? Well, the models can't answer that question. They've run out of road when you get to that level of detail. but the detail, the granularity that is there is quite important. There's a lot of detail, granularity on schools, as Paul quite rightly says. And the reason is because these have their ancestry in flu models. Children are very important. School-age children in schools are very important in the transmission of flu. So the models were very good at coping with them. They didn't have care homes in them at all at first. But where we really needed the granularity for this wasn't schools. There's very little going on in schools. There's never been an outbreak in a school worldwide that we know of. But care homes is a different matter. They were in the models. Another very good example of the granularity problem is contacts. Contacts are defined by the models due to people's self-reported behavior, who they see. It doesn't say whether they see them indoors or outdoors. There's a massive difference with this virus about indoor and outdoor contacts. One that has been now captured by policy, and hence the releasing of restrictions about outdoor activities in particular, because it's very obvious those are far, far safer than indoor activities. The models don't cover that. They don't distinguish between those two kinds of contact.
Okay, thank you on that note. Baroness Hilton.
Yes, if I could just pursue the last point about care homes and hospitals. Presumably the models predicted the crises in hospitals, but don't seem to have predicted the crises in care homes, although both Spain and Italy had serious problems with deaths in care homes. I don't know whether you'd like to comment on that in view of what you've just said about particularity.
If you'd like me to answer that, I'm afraid I haven't studied in detail the models from Italy and Spain. What's happened, I can give you some empirical data. I'm based in Scotland and I'm part of the National Advisory Group on COVID-19 for Scotland. And during the time of the lockdown, I'm just reading some figures here, the deaths that are distributed in Scotland, at the beginning of the first week in lockdown, a quarter of them were in the over 85 age group. Now it's more than half. Less than 10% of them at the beginning of the lockdown were in care homes. Now it's more than 40%. So what's happened is there's clearly been a differential between what's going on inside and outside care homes. Now, my models don't capture that. And I'm not sure that the other models capture that.
Mm-hmm. Thank you. I can go on. Sorry, did someone else speak? Sorry.
No, Baroness Hilton, it was me, Naren Patel, asking you to go on with your question.
Okay. I was wondering whether the modelling that is now being undertaken actually assesses different approaches to how we might lose some of the current restrictions on people, and what next steps should be used to manage the pandemic in future.
Well, as modelers on SPI-M, we're being asked to consider different scenarios. So, for example, the current program of school reopening was one modelling exercise that was given a few weeks back, and we were asked to sort of assess the impact of the school opening program or gradual opening program under a range of possible efficacies of the policy or responses to the policy. So if only a certain fraction of the schools go back in, what will that impact be? And if that releases a certain fraction of the workforce to go back to work, what is the likely impact of that policy going to be? Now, sorry, I've forgotten a little bit the thread of the question.
It was really about what next steps should be taken and what models you will use.
Right, yeah. So this will continue to this process will continue in terms of modelling challenges will be fed down regarding future policy steps, and I think all that we ask for as modelers is as these things are implemented is that we have the time to sort of assess, to get some data back on even if it's just preliminary data, to get some data on what's happening and what the impact of that relaxation has been before the next raft of measures it begins to be introduced.
Are you looking at data from other countries as a result of their loosening restrictions?
So I think the data from Italy does get looked at by some teams, certainly. I've been working with ECDC in terms of their Europe-wide modelling. So we get some feedback, and we get, as I mentioned earlier, there is the primacy maybe should not necessarily be on the models, but the assumptions that are used and the data that's used to underlie those assumptions. And what we put into our models outside of what is dictated by the modelling exercise is usually informed by what we can pick up from around the world and what's more relevant. So initially in the pandemic, we were reliant on information from China because that's where the outbreak was. But now we think that data might not be as relevant to us as what we're now observing from Italy and Spain and France. And so therefore the data from those countries is what, wherever relevant or wherever it seems to be relevant, will inform those assumptions that we make.
Okay, thank you very much. Lord Brown.
Thank you. Sorry. So, in asking this question, I'm conscious of your earlier remarks, Professor Rowehouse, that we should bear in mind what these models that we have been discussing mainly were set up to do. But so the social distancing intervention was introduced and accompanied by a lot of alleged expert commentary, whether it was or not, I don't think really matters for the purposes of this question, but that people were surprised that stronger measures had not been brought in. And then relatively shortly thereafter, about the 23rd of March, in what was described as a dramatic change in direction, we moved to a lockdown quite quickly. So the question is whether the data and the output from the models backed up these respective timings relatively soon after each other, respective timings of these decisions.
Thank you. That's a very interesting and important question. So at that stage in March, we're at the exponential phase of the epidemic in the UK. We've seen that exponential phase in other parts of the world, not least China, where, as Paul quite rightly said, the best data were coming from and most information at that time was coming from studies that were going on in China. Now, when should you introduce a lockdown? Well, if the measure you're introducing to control the spread of the epidemic is designed to be permanent, then unless it's very, very costly in other ways, you should introduce it immediately. That slows the rate of spread. If the intervention that you're planning to introduce is a short stop emergency measure, like a total lockdown, while you work out what to do, well, then the right thing to do is to delay a bit. And so the answer to the question of what the right time to introduce the measures was depends very much on when you think you're going to remove them. Now, when my group was looking at this, and some of our work is, I think, published in the SAGE papers on this, we were considering an emergency lockdown of 6 weeks. And we tried to optimize the timing with that in mind. We would have given, and we said very clearly we would have given a different answer, because we explored this, if we'd been told it was going to be 12 weeks or 18 weeks or 6 months or however long it's going to be. The answer is different. So it's one of those issues where the answer you get depends on exactly the question you ask.
Yep. And Dr. Birrell?
Yeah. If I could add, so in terms of and I think Mark's answer is absolutely excellent, actually. And I think in terms of sort of theoretical epidemic models, what we all learn about when we're new to the subject is that there's always a right time to intervene, and there's a potential that if you're going to implement measures for a particular length of time, will they lead to a second wave of infection that is more severe than the first? Particularly, there was concerns initially in this pandemic that after a release of mitigation measures, you might cause a second wave of infection bang in the middle of the flu season, which would be particularly disastrous because of the burden to the healthcare services. So that is kind of what we're always taught, and there is an optimal timing, an optimal timing for a particular intervention, and I think we all were, as modelers, we were all thinking about that. If we can implement a measure for a particular length of time, when is the optimal time to place that measure? And I think around about mid-March, I think the tide turned sort of at a meeting of SPI-M that I noticed about the 13th of March. There was a shift from this sort of more theoretical thinking to we need to lock down now to preserve the overwhelming of healthcare services. And I think in practice that has been borne out in that the epidemic had a doubling time of between estimates range from between 3 to 6 days. So that means if we delayed by 6 days, that's to be conservative, we could have had double the demand on healthcare services. Admittedly, that'd be highly localized, but that's perhaps even worse. So in the end, the timing, one way or the other, was not orders of magnitude wrong, certainly.
Okay. So my supplementary question to this is, with hindsight, do you think the model outputs, could have been used to support different interventions or timing of interventions, perhaps earlier than when we got to lockdown?
Yeah, yes, as I've just said, if you ask a different question, if you say if you're going to lockdown for 6 months, when you should start it, the answer was you should be started earlier. That was very clear.
I think Mark presented, if I remember rightly, a paper at a SPI-M meeting in might have been late February or early March, which showed that a gradual introduction of measures perhaps would be more effective as well.
But again, starting earlier. If you're going to introduce them gradually rather than a block, then you start earlier.
Yeah.
Okay, Lord Borick.
Yes, my question is about the public understanding of these models, and clearly at the beginning of this communication task in February and March, the task was to persuade the public to take it seriously, and that clearly has worked very, very well. Now we have a different problem, which is to get people to understand that it is possible to slowly move out of the very early rigorous rules, and people are having some difficulty understanding that. I've noticed in the daily press conferences, people saying yesterday, well, it hasn't moved from level 4 to level 3, so why are we opening up? As if that was a sort of click and instantly the country changes, and it's obviously much, much more complicated. And the concentration on R, when R appears to me to be an average over London, the Shetlands, over individuals in flats with hospitals and with care homes, very, very different groupings, and all pulled together into the one magic figure of R. Are we getting this communication with the public right, in your opinion?
No, in my opinion, we're not.
How could we do it better?
Well, the focus on a single R, as you quite rightly summarize, has, I think, been a distraction. I've argued consistently for a long time now that to use a single measure as a metric to drive policy would be wrong. I don't think it is being used as a single measure to drive policy, but the impression is out there that this is a particularly critical number. The original policy goals that I understood and therefore have been considering in all my work on this have been to save lives, to protect NHS staff, and to reduce the burden on the NHS as a whole. R has a loose and imprecise connection with any of those policy goals. One way to illustrate that is, I think it came up in the previous session, was that what appears to have happened over the period of lockdown is R has come down quite significantly in the wider community. but it has not come down and may even for a spell have been above 1 in care homes. Well, that immediately tells you R isn't the right thing to be looking at. It's the wrong way round. If I wanted R to be below 1 anywhere, I'd want it to be below 1 in care homes. So I think it has been a distraction, and it's kept our eye off the ball, which is, as I keep coming back to this, the population over 75 or over 70. And that's where the risks, the public health risks lie. And R does not capture that.
And I think the interpretation of R has, well, it's not changed over time, but its usefulness has changed over time. So when we're in the period of exponential growth, the growth rate is the more useful, and that the R does not give the rate of growth because it doesn't tell you how quickly people are being affected. But essentially, at that time, the epidemic will grow while R is greater than 1, and it will decrease if it is switched around. But that's really useful when the epidemic is widespread. When the pattern of infection becomes much more heterogeneous in the population, such as the description that Mark's just given of the care home epidemic, that is when R uses all utility, and we should be looking at different metrics.
Would it be possible to invent an R-type figure for those over 75 and publicize that? And would that be useful as a way of communicating where the problem is?
I don't have a fully formed answer to that, I'm afraid, but my personal view is that we should probably go back to old-fashioned public health and think about in terms of risk. What is the risk to an individual in this location at that time? Apart from anything else, that's very helpful to the individual concerned to allow them to make informed choices about how they behave. I'm not sure whether the R number helps an individual decide how to behave, but it certainly doesn't help me.
Yeah. All right. Yeah. Lord Boric, you finished?
Yes, indeed.
Baroness Blackwood.
Thank you, Lord Chairman. And I'd just like to follow up on some of the back and forth that witnesses have had with both Lord Hollick and Lord Brown about really the nature of models, which is you get out about the questions that you put into them, really. And I think it was Dr. Birrell, you said that you've been sort of asking questions of your models outside that which was dictated by the modelling exercise. And Professor Woolhouse, you've mentioned, I mean, a number of comments about whether there should have been population-wide questions or targeted policies and around age or care homes or shielded communities. So what I'm wondering is exactly what is the process of asking you, the modelers, questions of your models, and do you get any say in how those questions should be asked? Dr. Birrell.
Yeah, excellent question. So the groups that feed into SPI-M are academic groups, so they're free to pursue their research agendas as they see fit. But there are questions and modelling requirements that come down from SAGE. So presumably they've again come down from Cabinet Office, that are then fed to SPI-M, and they're usually modelling requests that have a very short turnaround time. Typically 2 to 3 days and often over weekends. And so therefore there isn't often the wriggle room to address anything other than what is being particularly posed. There is then the opportunity to sort of feedback via SAGE and then onwards what we might think of the modelling exercise, but essentially the exercises that come down that have a strict deadline and to inform a particular policy decision, there's not a whole lot of room for interpretation and sort of addressing questions other than that which has been put down from on high and from SAGE. Yes.
Okay, so Professor Woolhouse, you mentioned specifically that your model does not include specific data points or parameters that you think perhaps should be included, whether it's age or shielded communities. Are there measures which you think going forward should now be modelled in order to improve our response to the pandemic as we ease the lockdown?
Thank you. So the short answer to that question is yes, but our understanding of how this epidemic is progressing and how to control it doesn't need to be just based on models. You can do an awful lot with old-fashioned epidemiology, including things like the contact tracing exercises. So I think it's at this stage, in some respects, certainly the fine granularity that we talked about earlier, the models are starting to run out of road, and we need basic epidemiology at local levels in different parts of the population, different workplaces and so on. So I think in a way, the focus shifts from the models to the data. We need more and better data.
So if we're shifting from modelling to measurement for a lot of the areas, what role would you say modelling has in that intersection going forward? And how would you improve the role and the way in which models are used for the remainder of this period?
I think the simple answer to that is we would like the models to be tested and calibrated very closely against the data relative to the relevant data to what's important to measure at the time. So as I say, my feeling over the current period of the lockdown is there was not enough attention in the models to care homes. And we've discussed that many times. And indeed, the data from care homes has been difficult. And that's been a source of frustration to my colleagues on COVID-19 advisory group in Scotland, that we haven't got all the data we need to make informed decisions. So it's not just about models, it's getting the right data, the right information, and the word you use, measurements.
And if I can just come in on that, what the models can do, and what we're finding is that we can find areas where the models disagree. And they're not always on the quantities that are of particular interest to a particular question. But for example, we're currently discovering that there is discrepancy in the underlying number of estimated infections. Number of cases, symptomatic infections, they're easier to get at. But the invisible infections, they're harder to get to. And these are the quantity that the data on antibody testing should inform. But we have data from various sources of antibody testing. But they're usually the data gathering in those studies is opportunistic. So they're the data that have their own biases, they have their own weaknesses. So they maybe only sample a particular subset of the population, or maybe I use data from the National Health Service blood transfusion service, and these people cannot have had symptoms in the 2 weeks prior to giving blood. So automatically you know that you may be getting good sample from them, but you know that these people couldn't possibly have been infected within a certain period of time, because simply through their inclusion in the data. So there is a demand there that we've identified, that we need this kind of data to be able to build a better picture of what's going on.
Okay.
Thank you.
Lord Keika, you wanted to come in.
Questions. First of all, are you content that from whichever source these questions are coming, the correct questions are being asked of the models and the data that you have available, and that the limitations are properly understood by those asking the questions, and that you're in a position, or fellow modelers are in a position, to dismiss those questions if the methodology for the modelling that you have available to you is inappropriate to address the question? And secondly, just to come back to these, Professor Woolhouse, you made the point about the internal validity checks. Do you have examples of models where that kind of internal validity testing has been undertaken as data become available and models have been discarded as a result?
Well, thank you. Can I take the second question first? And the short answer is no. I haven't been over my colleagues' modelling efforts in detail. I don't know what exercises they've taken. Sorry, and the first part of your question was?
Are you content that there's an understanding about which questions are appropriate to put in terms of the modelling that we have available, and that the limitations of those models are understood by those who are putting the questions?
So I'm going to defer to Paul for that, for the context of SPI-M, because he's more embedded in that. But I will make a quick comment on behalf of the COVID-19 advisory group in Scotland, where I am very satisfied indeed that right up to ministerial level, there is a very good understanding of what isn't being said by the models and the other sources of evidence that they're being asked to design policy on. I think there's a very healthy exchange of information and knowledge in both directions there. So I think the communications in that context are very good. But I'll leave Paul to talk about SPI-M.
Okay, if I may also address your second question with a slightly pedantic answer first, because it's very quick. It's very, very rare that I think models should be discarded. Again, it's a point I made earlier. It's more the calibration or the assumptions used in the model, and maybe they need to be revisited rather than the whole model being thrown in the bin. So it's more a case of, rather than eliminating a modeling group or a particular model, it's more having a rethink about how that model is trained and what information is informing the model. Second, going back to the first point, it's my experience that so the SPI-M will regularly produce consensus statements about what goes forward from our modelling and what we can sort of say it summarises the things that we agree on and identifies points where we don't agree and therefore are still uncertain and further work is needed. And in essence, I think these statements are usually quite simple. Where there's a agreement, that we can quantify, it's quantified within a reasonable range of uncertainty, and that's I think that line of communication is acceptable. As we said before, often the wrong question is asked in the first place, though. So we can provide an answer that is understood, but maybe the wrong question is being asked in the first place. So a number of times we've been asked to provide a modelling scenario, and that meant a single epidemic curve. And a simple epidemic curve is not useful, I think, because it's going to be wrong. And how wrong that is, I mean, you're setting yourself up to fail if you only put forward one epidemic curve, because then something will not agree to it in the real world. And particularly earlier on, too often we were from SPI-M, single epidemic curves were going forward for planning purposes, and I think it's been a battle to sort of communicate that we should always be providing a range of possible values that hopefully will encompass something like what eventually transpires.
Okay, thank you very much. I've got 8 hands up and I've noted all of you. I don't know that I'm going to get you all in, but before any of you get in, I'm going to have a go. So Professor Woolhouse, you said, well, what we need to do now is move from models to basic epidemiology, the standard epidemiological methods. But you're hampered, and as I understand you said, by lack of data. So the question is, how do you get this data?
So there's a lot of work going on this to design the kinds of surveillance and monitoring system you ideally need. It needs to be stratified, just as we agreed, I think, well, amongst ourselves anyway, that perhaps a single R wasn't the most useful metric for measuring the rate of spread. Same thing with a single incidence figure, a single number of new cases per day, a single figure for the COVID-19 mortality rate. No, these are all figures that need to be broken up. They need to be granular by geographic location, age group, risk group, occupation, and so on. And we can't get away from needing to know about pretty much every segment of the population. But standard epidemiology says you concentrate most of your efforts where you're most concerned. So particularly important to get the data in hospitals and care homes. And that is starting to happen. But the data management systems we have in place through NHS and what I'm more familiar with, NHS Scotland, are frankly very cumbersome indeed. And it has been difficult to extract the right data at the right time for the right person in the right place. And there's a lot of difficulty. That's a historical problem. I've been complaining about that for about 10 years now.
And from what I understand from your answer is you need this to go forward to manage the pandemic in the future, right?
The better information we have with the sort of granularity that I and Paul have talked about, the better we can manage in the future, manage the epidemic in the future.
Okay, so please can I ask the others to be brief, and we might get as many questions as possible. Lord Ridley, Baroness Sheehan, I think Lord Brown, and Baroness Young. I can't read it.
Very quickly, Lord Chairman, thank you. I'd like you to clear up a contradiction between the first session and the second session. Professor Keeling said in the first session that the models have been, and I quote, very good at predicting outbreaks, whereas Professor Woolhouse has just told us we don't know what's going to happen next. We can't predict with this virus. I don't understand that contradiction.
I didn't hear Matt Keeling's exact words, so I don't know. The reasons we can't, well, what can't we predict? We can't predict the long-term behavior, and Paul said this very clearly at the beginning, that we can make fairly simple statistical-based forecastings for, I think you said 2 weeks, Paul, and I would agree with that. Longer term, there are too many uncertainties. No, I don't think we can make predictions. And then Paul gave the right answer a moment ago. What you do in that circumstance, you explore a wide range of plausible scenarios so that you have some idea yourself of what sort of uncertainties you're looking at.
Baroness Sheehan.
Just following on from your own question, Lord Chair, the importance of implementing a targeted response as opposed to a population-wide response has been made quite clear. Do we need to wait for the data before decision makers can act on that? And how important do you think it is that we do act on that immediately?
Brief answer, please.
Yeah, I think particularly in the case of the care homes, we have the data so we can act on that. But generally, I mean, you need, I mean, you can't, without data of any description, you can't really direct your response. You can because you don't know how to train your model, but there is always some data available somewhere. There's always something relevant you can pick up. But the more data you have, data is almost, in my opinion, data should have primacy. Data is the more important thing, more than any model.
Lord Brown, did you want to come in, or I go to Baroness Young? No.
So I don't go to Baroness Young.
Okay, Baroness Young.
Chairman, thank you. We talked about individual researchers pursuing their research interests. Where should the forum be where researchers get together to talk about modelling strategy, what the questions are that should be asked that they may not being asked by number 10 and the Cabinet Office at the moment? Is there a forum for that researchers can decide what the questions ought to be?
The academic community, not just the modelers, the entire academic community has been extremely engaged with COVID-19 from the outset. 2 examples, the Royal Society has an independent modelling group looking into questions like that. There was a report by Delve, one of their groups that did that recently. And I've just been attending earlier this week quite long workshop at the Isaac Newton Institute in Cambridge. Lots of modelers and epidemiologists talking about alternative strategies. The work is being done, but it's not necessarily, as Paul said, being done in SPI-M.
So what do you think from all the information about epidemiology and of the model tells you what the short term and the medium term likely scenario is going to be?
Well, we're in a particular state of flux at the moment. So we're in with the loosening, the gradual loosening of lockdown measures. We no longer can predict the behaviour of the public over the next coming period. So it's highly uncertain. with each measure that gets relaxed, we get closer to a regime of R equals 1, and then around R equals 1, very different futures can happen. So it's an exciting time. We have to wait and see, I think.
I don't think it's exciting. It's
well, in terms of it's an excitable system in that what can happen is quite volatile.
Professor Woolhouse, last comment.
Yes, what I would say there is what I think most of the modeling community are concerned about now is that R will increase, let's give a hypothetical number, to something like 1.1. What I don't think anyone is truly expecting is that we get back to R values of 2 or 3 or higher as they were at the beginning of March. So what I'm characterizing this is we're concerned about a second bump, but not a second wave of the kind we saw in the first wave of the virus at this time.
If I've got time to add to that, the challenge there is that R of 1.1 is difficult to detect.
Yeah.
So epidemics that have an R of 0.9 and an R of 0.1, and we're being over-reliant on R in this conversation, but regimes of that are very difficult to differentiate for a long time. So that's the challenge that's coming.
Professor Woolhouse, as somebody who advises the COVID-19 committee in Scotland, I have greater interest in that, as you might well understand. I'm north of you. So do you think the divergence that we see is appropriate to the information we have?
So the scientific advice, or sorry, the scientific evidence about this virus is building at an enormous rate. Vast volumes of information are coming. It's sifted through committees like C19AG for Scotland or SAGE for UK. People are reading it and interpreting it. It is then being passed on to policymakers with those interpretations on them. I'm not at all surprised to find that policymakers, not just across the UK, but across Europe and the world, are having slightly different interpretations of what they've been told, and that will go on.
Okay. Well, I've overshot my time, but I've not been cut off, which is surprising. But can I thank both of you for helping us today? It's been a most interesting session. We appreciate it very much. Thank you very much.
Thank you.
Thanks very much for the invitation.
I think the broadcast will switch off.